Probably should have started the recording when I started talking. All right, so we'll get right into it. Like I said, immunologic emergencies, this is mostly going to be dealing with the body's reaction to either most likely itself or something that's a foreign invader within it. Um, Mostly going to talk about allergies, and as an EMT, you're going to respond to this a lot, especially all down there in the South where people tend to get outdoors more often. Um, the months are warm longer, so people don't they don't go into hiding or hibernation like they kind of do in other parts of the country. Um, so people are more likely to get stung by bees, more likely to come into contact with some kind of pollen or whatever that may cause some major issues. Um, some of the things you're going to run into with allergy related emergencies are going to be airway obstruction, which is your biggest issue, and then if you can catch it there, then fantastic. Um, if it gets too bad though, and we don't intervene, then it will lead to cardiovascular collapse. That's where you're going to wind up doing CPR on somebody when you really, hopefully, should have never had to get to that point in the first place. You have to be able to treat these life-threatening conditions because if you can't, they're not going to last long enough to get to the hospital. It's going to wind up being like one of those aneurysm scenarios we talk about, where it's like your patient's dead before you get into the hospital. This is something that has to be fixed in the field at least to the best of your ability. Sometimes it may not happen, and you may need a paramedic, um, but hopefully that's not the case. Or if it is, you already have a paramedic, and then they can kind of pick up where your scope ends off. You must also be able to distinguish between the body's usual response to an allergen and an allergic reaction. All right, so a real quick recap of anatomy and physiology for this. The immune system protects the body from foreign substances and organisms. When a foreign substance invades the body goes on alert. It kicks in your positive feedback loop. Remember that? So fever, it basically goes into attack mode and is trying to kill off whatever's inside of it. Your body normally likes to stay at 98.6 degrees. So does the stuff that gets inside you. So if you're dealing with an immune issue because of a sickness or something, your body's going to do that. The body's response to an allergic reaction is going to be treated kind of like an injury. You run into, your body says, all right, well, we need to get these antibodies to fight this infection off. And the problem with allergic reaction, it's a normal body response taken way overboard. So you run, the body would normally dilate your blood vessels a little bit just to increase blood flow, get more antibodies around the body faster and everything. But if it overreacts, then it's going to dilate much more. And the problem with that is, what if, remember we talked about this earlier in anatomy, if the blood vessels do one thing, what does the airway do? Generally speaking, if I introduce something into the body that's a vasodilator, going to make the blood vessels bigger, what does that in turn also do to the airway? It constricts. It's the opposite effect. If I give a bronchodilator, is going to be a vasoconstrictor. They work opposite each other. So whatever you do to one, you're going to do the opposite to the other. And that's the problem, is because the body is not trying to choke itself out. The body's trying to get more blood flow to get more antibodies because it thinks there's an army when it's really only one thing that it's got to fight. Um, and as it dilates your blood vessels, it constricts your airway. And so therein lies the problem with an allergic reaction, especially on par with a 911 level allergy. So anyway, it's pretty much what happens. Your anatomy system or your anatomy review is pretty simple tonight. It's basically your body's going to release various chemicals and cells to fight infection. We have white blood cells, we have antibodies, we have histamine that's released. Histamine is actually what causes, when you think about an allergic reaction, it's actually the body's histamine response that you're seeing. So the drop in blood pressure because the veins are dilating, the airway constriction, all of that is caused by a histamine response. So if you think about it, that's why if you have an allergic reaction to something, a mild one, for example, we take an antihistamine like Benadryl. Right? We'll pop one or two pills, fights off whatever issue we got going on. Usually it makes us sleepy. That's a side effect of it. But what we're doing is we're blocking that histamine response so that those symptoms go away. Whoop, too far. So an allergic reaction is an exaggerated immune response to any substance. The first time you encounter something that you're going to be in the future that you're going to have a allergic reaction to, you usually are fine with it, right? Your body, like for example, if you have a peanut allergy, the first time you encounter peanuts, your body is fine. It sees it as a problem, builds up an antibody resistance to it, and then you go on about your day. The problem is usually from the second interaction on. Every time it comes around after that first time, it's when you have the overreaction. It's not caused directly by an outside stimulus, such as a bite or a sting. Sometimes it is. Rather, it's what it's saying there is that it's not directly like the sting isn't what's giving you the reaction. The body's response to it is what's doing it by the chemical release of histamines. Some patients may not know that they have an allergic reaction because we're not born with all of them, and we actually develop some as we age. We kick some to the curve as we age. It just depends. There's been people that have developed a shellfish allergy, which if it ever happens to me, you're probably going to put me in a crazy person's home because I love my shrimp and crawfish. But I mean, it happens, right? There's people that develop certain allergies later in life. Their body just decides to start fighting it for whatever reason. An allergic reaction may be mild or local, so it'll be characterized by itching, redness, and tenderness, or it can be severe and systemic. These are the ones that we got to worry about as EMTs. That's what's also called anaphylaxis, and that's what takes you down the shock route. So we don't want that. Anaphylaxis is an extreme, life-threatening allergic reaction. This usually involves multiple organs. So at this point, it is truly systemic. Um, if you're going into anaphylaxis, that means your cardiovascular system is messing up, your respiratory system is messing up. It's not just like, oh, I got something on my skin or whatever. In severe cases, it can result in shock and death. There's three common causes. To the right. Yep, there we go. We have urticaria. I said common causes. I meant common signs. I apologize. Urticaria, which is hives. That's what you see in the picture. These are small areas of generalized itching or burning that appear as multiple small raised areas of skin. So if anybody besides me has a stupidly high allergy to, say, like poison ivy, um, this is what you would generally see. It's a contact allergy. Sometimes a little bit more sensitive than others. Like I actually had a full body breakout because I got in the smoke from somebody burning poison ivy at the next property over from me. That was miserable because it was everywhere. There was, it got through my clothes. There was no, it wasn't just wherever my hands went. It was head to toe, um, in my nose, in my ears, in my mouth, all that. That was bad. I was a kid. I still remember that. Angioedema. This is areas of localized swelling. So as you can see here, this lady's tongue is what's swelling up. This is a pretty, well, I'll say moderate allergic reaction. It's just the way that her body reacted to it is pretty bad. Now, this obviously, what's your biggest concern if this is your patient? Yeah, yeah, airway, right? That's a pucker factor. If I walked in and saw that, I'd be like, oh god, because there's no way you're going to put an OPA in that. And I mean, granted, if she's awake, you're not going to do that anyway. But that's a nightmare scenario for keeping somebody's airway open as a tongue that's swollen up that large. Wheezing, you'll hear this when they start to go down the bad allergic reaction routes. This means that their airway is starting to become compromised at a lower level. So it's a high pitched whistling sound. Um, Usually you hear it on expiration. If you hear it on both, they are severely bad off. It starts off, you only hear it on the exhale. You don't really hear it on the inhale, but it will, as it worsens, you'll start to hear it both ways. Try your going through the You mean try your lips?
I had a bad allergic reaction, and my lips, they swell up huge. And when I say huge, I mean big, big.
Big like
And they fold down over one another.
hmm
Yes.
Wow. What happened, if you don't mind me asking? What were you allergic to?
I was allergic to it was a medication that I had been fighting fire, and I had a reaction to poison ivy,
Hmm.
and it broke me out. So I ended up staying in the hospital for about 2 weeks.
Oh crap. Well,
Yes.
obviously, I'm glad you're all right. Glad you're in the class and not.
Oh yeah.
But wow. All right. So again, kind of following along the progressively worse reactions of these slides, you may also notice hypotension due to vasodilation and increased capillary permeability. So, you know, cap refill less than 2 seconds. Hooray! It's great. That's what we want, right? But it really doesn't. Like I said, that's just in this case, that's a sign of something the body's overreacting. If you squeeze a nail bed and it goes back to pink as soon as you move your finger off of it, that should tell you that there's some serious vasodilation going on. Because yes, you want it to reset quick, but not that fast. And then the hypotension issue due to vasodilation, again, that's not the problem unless they're crashing. If it's so bad that they're like about to go into cardiac arrest because their blood pressure is going into the pits that they can't recover, they can't move any blood, then it's a problem. But at that point, for their vessels to be that dilated, their airway is probably completely shut off, and that is still your priority. GI dysfunction, nausea, vomiting, abdominal cramps, especially if it's something like a peanut allergy that you ingest, your GI tract is going to completely revolt. All right, some common allergies fall into 5 general categories. First of all, we have food. Certain foods like shellfish or peanuts may be the most common trigger of anaphylaxis. In fact, a really good friend of mine's son has some major, like if he's on just if it were any worse, he'd get it. He'd have an allergic reaction for being in the same room with a peanut. These foods account for 30% of deaths from anaphylaxis, and it's most commonly adolescents and young adults. Usually because we just eat anything we can get our hands on. Symptoms may take up to 30 minutes to appear. Think about it kind of like how we think about medicine, right? It's got to get into the bloodstream for the body to start releasing those histamines to fight it. And so it takes a little bit to be digested and get through the portal circulation to that point. This may not include skin signs because it's not a contact. This is something that we ingested. Your skin signs are typically because that's where you came into contact with the allergy. So, if let's say it's something in the shellfish or the peanuts, if there is a skin contact reaction, it's probably going to be the fingers where they actually grab the food from. The reaction can be severe and involve the respiratory and or cardiovascular systems. All right, medication, same slide. Medications are the second most common source of anaphylactic reactions, particularly antibiotics. So a lot of times when we're asking our sample history, one of the things that we're wanting to know when we talk about allergies, we're mostly concerned about medication allergies, but it's still good to know about certain foods because there's medications in the hospital that the docs can't give if you're allergic to egg or other certain other ones. Your flu shot. I think your flu shot, if you're allergic to eggs, you can't get the flu shot. So keep it in mind. Reactions to oral medications, just like food, may take up to 30 minutes to appear, but it can also be pretty severe. And one of the biggest issues with this is by the time you start to see the signs, that means your body's got a pretty good amount of that food digested and working its way through the portal veins. So you're probably going to be fighting that reaction for a while, which you'll see when we start talking about epinephrine and how long it lasts. That can be a major problem for us in the field. My daughter discovered she is allergic to strawberries. She can't drink her daiquiris. I mean, I tell you what, there's a couple of things in that it gets me through my day and keeps me from being an alcoholic and other things. And if you take that away, that's going to be a problem. So I get it. I feel her on that one. Plants, dust, pollen, and other plant materials can cause a rapid and sometimes a severe allergic reaction. So you're going to see these more seasonally. Um, some common plant allergens include ragweed, ryegrass, maple, and oak. And oak is the big one that's getting people this time of year, especially up in the part of the country that I'm in right now. Chemicals, certain chemicals like makeup, soap, hair dye, and I will even toss in laundry detergent. I've noticed a lot of people having mostly contact reactions actually, but some people just don't handle laundry detergent very well. Um, they make some hypoallergenic ones that are out there. So if any of you guys are struggling with skin breakouts and stuff, that may be one of your issues too. Latex. Anybody still use latex gloves at their departments if you're on a department? Or did y'all already switch over to the nitrile ones? No to the switch or no to latex? Latex free. All right, good. Yeah, most people are. Some departments are kind of behind the curve, but we found out a lot of people are allergic to latex. The lesson plan says 12% of healthcare providers, which, if you think, I mean, we're talking about nationwide, industry wide, all levels, everything from the first aid person all the way up to the doctor. That's a lot of people. Nitrile gloves are a great alternative, at least for now. We'll see. People start developing a bunch of allergies and sensitivities to that, and then I guess we'll move on to something else. Insect bites and stings. So typically we think about the bee sting. Um, my sister is pretty good with bees now, but she was pretty deathly allergic to ants when we were kids. And she get bit by one ant, and that was a trip to the ER. And we lived in Jasper County, Mississippi. There's ants everywhere. The reaction can be localized for bee stings. Most people, when they react, they usually react locally. They don't have a systemic infection or reaction unless they are truly like her. They're just deathly allergic to it. Um, Maybe a severe and a systemic reaction when it gets bad. Oh wow, I got a little ahead of myself. All right, there we go. Approximately 3% of adults and 1% of children are allergic to the venom of bees, wasps, hornets, and allergic reactions to insect stings account for at least 50 deaths a year. It's not bad, but I mean, it's an odd thing to die from. So especially with the availability of EpiPens. And about half of these deaths, the victim had never experienced a reaction prior to the sting, so they didn't know that they were that allergic to it. The stinging organ of an insect is small, hollow, and usually that's where like the venom sac is going to be. So we'll learn in this chapter. Like I said, if you've ever been an EMR or first aid trained, you've already learned how to remove a stinger. We'll talk about that. Um, Not necessarily in this slide, but it's coming. All right, venom can be injected through the stinger directly into the skin. Honeybees cannot withdraw their stinger. They're a one and done, right? But they can still sting you. The honeybee flies away and dies. If the stinger is not removed, it can continue to inject venom for up to 20 minutes. So if the initial sting wasn't enough to throw you into anaphylaxis, leaving that stinger there will definitely do it if you're susceptible. Because they fly away, it can be difficult to identify which species is responsible. For bees, that's not so much of a big deal. If it were a snake, it'd be different. Um, but wasps and hornets, those are the assholes. Those are the ones that will sting you and continue to sting you. They don't die. They just keep attacking until you remove yourself from their situation. Some ants, especially the fire ants, there we go, which is like the most densely populated portion of Mississippi, is the fire ant. They also strike repeatedly, often injecting particularly irritating toxin at the bite sites. Anybody never experienced a fire ant? I know none of y'all are from like New York, so I'm pretty sure everybody's had a nice little run-in with them before. Got bit by an ant on my toe. My face will swell. So yeah, it's not. So you've got a pretty big allergy to them then. Yeah, it sounds like you might be down the road with my sister. Um, they bite her, and then she's full body swelling up. I don't know if it's so bad for her now in this stage of life, but when we were kids, it was pretty horrible. Some signs and symptoms for insect stings: we've got sudden pain, swelling, localized heat. So it starts off kind of like a contact um, allergy, and then depending on how bad you are allergic to this, then you're gonna start to get systemic effects afterward. But you get widespread urticaria, which is that hives in the skin, redness in light-skinned individuals, itching, and possibly a wheal, which is a raised, swollen, well-defined area of the skin. Let me go back. That's what you're seeing in that picture. So anytime we want something to shrink down, all right, if we want to reduce swelling, if we want to reduce anything, ice is your answer. All right, cold tightens things up, shrinks things down. It constricts your blood vessels, all that stuff. That's cold will do that. If we want to relax a muscle, if we want to allow for more blood flow, if we want any of that kind of stuff, then we go the opposite side. We go to heat. So when you're dealing with an insect sting, um, we're trying to minimize the swelling in the area, the urticaria, um, the allergic reaction where the blood vessels start to dilate and everything. So ice will be the route that we go. That's what the slide is saying. The swelling associated with an insect bite may be dramatic and frightening, especially for people who have gnarly allergic allergies to these. As long as these manifestations remain localized, though, they're not really serious. It's when they start to become systemic. And the biggest thing that we're always going to watch out for is their airway. Go ahead. What's your question? If you need to, you can by all means unmute. All right. So your question is it true you have to have it in your body at least once to develop an allergy? Yes, that is true. Um, unless it's a legit toxin. Like if it's an insect sting is a little bit different because those are toxins developed biologically by that species that is meant to cause a reaction. So first time you get stung by a bee, you wind up in a hospital. Yeah, it's the first time you got stung. The things that typically have to always you encounter at once are things that aren't usually meant to be offensive like that. So a peanut allergy. First time you can come in contact with peanuts, they're ambivalent. They're not, peanuts don't exist to kill you. So that's the difference there. But yeah, no, toxin from a poisonous snake, toxins from bees, um, those are direct and first time. First time you get it, if you're allergic, you're going to know it because that's by design. That's their defense mechanisms. Good question though. Yeah, because that is, usually you always hear yes, you have to be exposed to it, but it's not that doesn't apply to everything. That's only in things that wouldn't normally try to hurt you. In more severe anaphylactic cases where you're dealing with anaphylactic shock, your patients may experience bronchospasm and wheezing because their airway is shutting down. Not by not on purpose. Again, the body's not thinking about their airway. The body's thinking about fighting off an invader. So it's trying to dilate the blood vessels, but that's the trade-off to it. Chest tightness and coughing, dyspnea, which is trouble breathing, anxiety because they're having a trouble breathing, gastrointestinal complaints, especially if it's food, hypotension, occasionally respiratory failure. And this at this point, this is because we either A, We didn't know. We didn't act. We didn't get there in time. They didn't know to call. It could be anything. But usually, if you're there, we should be able to stop them from getting to that point. If untreated, an anaphylactic reaction can proceed rapidly to death, and this is truly a race of time. So keep that in mind when you get there. Um, if you the minute you suspect allergic reaction, and I will tell you this now for your scenarios as well as real world. If you even have a hint that it might be allergic reaction and it's severe enough to start to compromise their airway, hit them with an EpiPen. You won't hurt them unless it's like a 90-year-old woman. Um, Hit them with the EpiPen. Uh, if it works, great. Then you know you were right. Worst case scenario is you sped up their heart rate a little bit. If untreated, anaphylactic reaction can proceed rapidly to death. More than 2/3 of patients who die of anaphylaxis do so within the first 30 minutes. So you went from fine to dead in 30 minutes. So rapid treatment and transport is essential. And keep in mind that includes your transport or your response time, right? They get stung, ow. If it's the first time they've ever encountered it, they're going to wait until they're already showing the symptoms to even call 911. Then you have to get dispatched by the dispatcher. Get there. Hopefully, you're not 20 minutes away. You might get you might show up with 60 seconds left before they circle the drain and die on you. That's the big issue with these. Is why these are so time sensitive. Patient assessment in an immunologic emergency. So as always, scene size up, BSI, scene safety. That's going to be the first words out of your mouth. Make sure you don't forget your gloves. And you can look at these, especially if it's something like a sting. When you're thinking about scene safety, first of all, consider your own allergic reactions or your own allergies, right? Are you allergic to bees? Because if you're responding to somebody that got stung by a bee, that means that the bee might still be there and you're going to walk into hostile territory and possibly get stung as well. So you can treat this like a shooter. If you have a bad allergy to bees, you may need to just send your partner, um, or see if the patient can get to you away from where the problem is. Because if you get there and then now you're having an allergic reaction that's going to threaten your life, that's no good. The patient's environment or recent activity may indicate the source of the allergic reaction. We have so sting or bite from an insect, food at a restaurant, or a new medication. Usually, the medications, if they have an allergy to it, they'll find out at the hospital. Um, I know that the hospitals I worked at, they had a rule where if they gave me a medication, I had to stay there for 30 minutes just in case I had a reaction. I'd already be there, and then they would let me go. If it was something I knew I wasn't allergic to, then fine, whatever. But if it was, they'd ask me like, "Here's this medication. Have you ever had this before?" And if I didn't know, or if I hadn't, then I had to sit there and take one while they watched to make sure I didn't have an allergic reaction. A respiratory problem reported by dispatch may be an allergic reaction. So if you hear trouble breathing, especially if it's something like at the park or at a restaurant, you can go ahead and be at least considering allergic reaction. So on your way to the scene, um, whoever's not driving can go ahead and be thinking about or looking into the bag as to where the EpiPens are. If you don't have them, you can let that be one of the first questions to your patient when you get there is, do you have an EpiPen? Consider your need for additional resources such as advanced life support. So, and I'll say this again when we start talking about the EpiPen. Epi only lasts for a couple of minutes, like 3 minutes, maybe 4 minutes. Um, if the allergic reaction is lasting longer than that, then when the epi wears off, they're going to go right back into their allergic reaction, and it's almost like you didn't get anything done. So, we only carry a couple of EpiPens, and a pediatric is not really going to do anything for an adult. You need to have enough of a dose. So, that being said, if you got one adult and one ped, you really only have one shot. If that's a bad allergic reaction, you're going to need the epi that the paramedics have that they can give IV or whatever, or they can give Benadryl IV, and they have other toys. We'll just say that. Um, but now you got to, if they're not with you already, you got to factor in their response time. So if you think you're going to an allergic reaction and it sounds severe, go ahead and call. You don't have to wait till you get on scene. Go ahead and call the paramedics as additional resources. And if you get there and find out that it wasn't as bad as it sounded, you can always turn on, you can disregard the paramedics. But again, you're talking about the bad ones, not, oh, I got a little red spot or something, or this bump. We're talking about the real life threat allergic reactions here. Time's not on your side, so the faster you can get units out there, the better. For your primary, quickly identify and treat any immediate or potential life threats. So as always, we worry about our ABCs here. Airway is going to be your biggest concern. It's also probably going to be your biggest battle because you're fighting the body, the body's trying to fight something else and it's not paying any attention to its airway. When you give an EpiPen or something to open their airway up, you're hindering the body from doing what it's going to try to do. So it's going to keep trying. It's going to keep releasing histamines and all that stuff to try to keep opening up more blood vessels to get more blood flow and shutting down the airway even more. That's kind of the problem with this. Do they run trucks with just EMTs? Absolutely. Most of your cities run basic trucks, even Picayune, Mississippi, which is not, that's barely a city. They run basic. They have a basic truck. So at least one. How many are you with us tonight, Wesley? Yeah, most of your 911 response, especially in Mississippi, is all paramedic and an EMT. But you never know if they're tied up. They might send an basic truck out to start the call until the paramedics can get there. And in your bigger cities, like Buffalo, New York City, they run double basic trucks as the standard response, and then all their paramedics sit in sprint cars. So the paramedic won't be on the truck all day. The paramedic will be in an SUV, and the EMTs will run the call. And if they determine that it needs advanced life support, they will call out for the paramedic. The nearest one will go. That paramedic will hop in the truck, kick one of the EMTs out, and that EMT will sit in the SUV and drive the sprint car behind the ambulance on the way to the hospital. And then they all get back in their seats at the end, which is good because we were in a major paramedic shortage. Um, so if any of y'all want to be paramedics, we need them, and that's a good way for cities to get around their shortage of paramedics. Louisiana runs paramedic and basic most places. Some places run basic trucks. Yeah, it's the same thing. That one basic truck in Picayune is supposed to be like a dialysis transport or non-emergency transport only. But if every truck is booked, you never know. They may go ahead and send you just to get a truck on scene while you wait for an ALS truck to get there. But, all right, form your general impression. Allergic reactions may present as a respiratory condition or as a cardiovascular distress in the form of shock, especially when it gets really bad. Patients experiencing a severe allergic reaction will often appear very anxious. Just think about what's going on, right? I've beat it to death that hypoxia is not your go-to sign for, or I'm sorry, cyanosis is not your go-to sign for hypoxia. Anxiety is. The first thing to mess up is the brain. So when you start seeing their anxiety climb, that should be your warning. Hey, maybe something's wrong with their airway. Look for medical ID bags or tags. Check their phone. Just ask them if they're alert. Just ask them, like, are you allergic to bees? Or what are your allergies in general? Let them tell you. But if they're already unconscious, you can look around for things that may have it written down. Your airway and breathing. Anaphylaxis is going to cause a rapid swelling of the upper airway, so you're going to see them get anxious. Then you're going to start to hear the wheezing. You might see the swelling of the tongue and lips. The wheezing will start off only on the exhale. As it gets worse and louder, you're going to start to hear it on the inhale as well. And then at that point, they're going to start getting tired and passing out on you. Hopefully, we don't just stand by and let that get to that point. You may have only a few minutes to assess the airway and provide life-saving measures. Not all allergic reactions are anaphylactic reactions. So if somebody gets bit by an ant, don't freak out and hit them with epi, right? I get bit by ants and I'm not allergic to them to that level. But if you suspect any airway compromise, then yes, they need an EpiPen. Even if it's, I would say even if it's mild, because the minute the airway starts to go bad, that to me is a severe allergic reaction. No allergic reaction that's not severe is going to cause their airway to start messing up. So you're going to quickly assess for increased work of breathing. What are some of the things um, that we consider to be increased work of breathing? Tripod position is a big one because it makes it easier for them to breathe. Retracting, yep. All right. So use of accessory muscles. Seesaw breathing if it's kid, wheezing, good. And then some other ones you may find inability for them to breathe through their nose. They're gonna look like they're out of breath. They're gonna very quickly go to mouth breathing when they start to have a problem with their airway. Um, their anxiety is gonna climb. Those kind of things. As the patient's condition worsens, breathing may diminish to the point of being almost silent. Hopefully, it doesn't get to that point, but sometimes it does. Stridor is another breath sound that we talk about in EMT school. This is a harsh, high-pitched sound heard on inspiration, and this can eventually lead to total obstruction. The patient may eventually fatigue and may even stop breathing. In the latter case, you're going to be doing at least rescue breathing, but probably more along the lines of cardiac CPR. For circulation, some patients in anaphylaxis may present with signs and symptoms of circulatory distress. So you're going to get that weak, thready pulse, right? Their blood pressure is going to drop. So palpate for the presence and especially the quality of a radial pulse. Assess for a rapid pulse rate. Their skin should be hopefully um, warm and pink, but some of the things you may see, you're going to see red, hot skin. You may, depending on what's going on, you may see pale, cool, cyanotic, like they're going into shock. It just depends. It depends on what the allergic reaction is. But if it's anything other than normal, that's a problem. Even red and hot, that means there's a lot of blood flow in the skin, which is normally a good thing. But in the case of an allergic reaction, that's something we need to take and keep in mind. All right, so treatment for shock, and this is pretty much any shock. We're talking about it now in anaphylaxis, but if it's hypovolemic, we'll do the same thing. If it's cardiogenic, we'll do the same thing. So treatment for shock, if I ever ask you what the treatment for shock is these three things. Oxygen, position them supine if they can take it, recumbent if they can't. And then prevent the loss of body heat. So loosen up restrictive clothing. We don't want anything that might wind up restricting their airway. And then cover them up, keep them warm. All right, so oxygen, warmth, and positioning is pretty much what I want to hear. Definitive treatment for anaphylactic shock is epinephrine, and usually it's a lot more epinephrine than what you carry. Again, that's what's in the EpiPens. Epi lasts about 3 to 5 minutes, and then it's done. It's almost to the point where I disagree with the slide saying definitive, because definitive means that you give it to them and then the anaphylactic shock is gone. That's not necessarily the case. So just be aware of that. You hit them with an EpiPen and they get better, great, but don't be real quick to grab that refusal sheet, because in about 5 minutes they may be right back where they were. For your transport decision, if it's bad enough to affect their airway, I would say they need to go. Like that, to me personally, I'd be like, we need to get you to the hospital, because this one EpiPen is probably not going to keep you from falling back into it. Again, they're quick burns. They're not meant to be long-term fixes. If an EpiPen is all they need, then it probably wasn't too terribly bad of a reaction in the first place. Sometimes they will last longer than what the reaction does. It just depends on how bad the reaction is. If anaphylaxis is suspected, if you're to the point of anaphylactic shock, um, then transport is warranted immediately. Get them in the truck and go. Because again, you're still even if you hit them with the EpiPen, again, you're still fighting with time. Take along the patient's medications, any auto injectors that they have, inhalers, that kind of thing. Anything that they can use to keep their airway open, bring it, because you may need it on the way. If the patient is calm and does not exhibit severe symptoms, consider continuing the assessment, but err on the side of the emergency transport. You really don't want to be the ones that get called into court because you got a refusal on somebody 2 minutes after an EpiPen hit, and then they died on you before you got out of their street. All right, for your history taking, investigate the chief complaint or the history of the present illness, identify any signs and symptoms. So we're going to get into our sample history here. Pay attention if you're worried about allergic reactions. Pay attention to the ones that matter. Signs and symptoms they're usually going to be the same for an allergic reaction, regardless of what the allergy is. Get their allergies, especially, sometimes we miss the allergies when we're trying to get sample because it doesn't really pertain, like in trauma. A lot of times people miss allergies, and I don't really ding you for it. It's just a point on your assessment, no biggie. But if you miss allergies on an allergic reaction, I'll probably fail you. Just because that's the big thing, right? It makes sense. Get their medical history, or at least I'm sorry, their medications. Um, at this point, any pertinent medical history, and then the last thing they ate is also important because it could be a food allergy. All right, so keep that in mind. If the patient is responsive, you can get it from them. You can also ask them OPQRST questions, like if there's any pain involved. Um, that can be some good things to ask. Ask if they've ever had a severe allergic reaction in the past, because if they have, they most likely have EpiPens. They most likely have some kind of maybe an inhaler or anything of that sort. Be alert for any statements regarding the ingestion of foods that commonly cause allergic reactions. So I always go to peanuts and shellfish. Anybody think of another common food allergy? Milk. Yep. All right. So, well, lactose intolerance. That's one. Yeah. I don't. That's a weird one. That's not. Um, it is an allergic reaction in a sense. It's really just the body's inability to break it down, and so it winds up causing food poisoning type symptoms more than allergic reaction. But it is. Yeah, you're right. Milk is one. Eggs are one. Actually, now that I think about it, because again, oysters. I wouldn't mind having an oyster allergy. That's one shellfish I could handle having. I don't eat them anyway. Don't judge me. All right. So anyway, moving on. Be alert. Let's see. I already said that. Inquire about the presence of gastrointestinal complaints such as nausea and vomiting. Yeah, those things are disgusting. Tastes like solid seawater. And solid's not accurate either. All right. So your secondary assessment. This is your head to toe. The big thing here, kind of treat it like you're treating a gunshot victim, especially if you think it might be an insect. Head to toe, look very closely. Sometimes the stingers can be hard to see. Somebody said that. I might try them. We'll see. It's been a while since I tried oysters. If indicated, perform a rapid exam of the body from head to toe, or conduct a physical exam focused on the area of the chief complaint. If it's a contact allergy where they're like, "Oh, I got this on me, on my hand, and my hand is red now," well, first of all, it's probably not a real good reason to call 911, but they're saying the problem is on their hand, and it's something you can see. So in those cases, just look at the hand. If it's something systemic, then yes, a head to toe is warranted. Or if they're at altered level of consciousness, head to toe is warranted. Don't just look at the hand. Do a full assessment. Try to see if you see any bites, any stingers, anything of the sort that could have caused the reaction. Get your baseline vitals. Because allergic reactions can lead to anaphylactic shock, you're going to be looking for signs in your vital signs that might be shock related. So let's talk about how the body, what the vital signs for shock typically go. When you're compensating, right, early on when shock starts to kick in, you're doing compensated shock at first. The body's able to make up for the problems with the perfusion. Couple of things are going to happen. Your vital signs are typically going to go up. All right. So your blood pressure might stay the same because that's the goal, but your pulse is going to climb. Your respiratory rate is going to climb. Um, those are going to be the signs that you're in compensated shock, is when those two things climb, but the blood pressure stays the same, or even if the blood pressure climbs a little bit, but it's still in the right range. Um, After a while, though, the body starts to wear out. Unless you can fix the issue, the body starts to wear out, which means that the heart rate's going to start to slow down. And if the heart rate had to beat at 130 beats a minute to maintain 110 systolic blood pressure, when the heart slows back down to 60, the blood pressure is going to start to drop. So now your heart rate's falling, your blood pressure is falling. Whatever the heart does, the lungs are going to follow. So your breathing rate's going to fall, and then you start to just drift. You fall off the cliff at that point. Like you're just tracking down. Your vitals are going down, and if you don't intervene, they're going to die. It's the same thing here. All right. So when we are watching our vital signs, that's what we're looking for. We want to make sure that we're not seeing um, certain vitals get out of whack. So think about what that means. I may do that. Some of your clinic, or your scenarios in the boot camp. I may give you all your vitals are good except your pulse and your breathing may be high, and I want to see if that triggers a red flag in you or not. I mean, as a student, it may not, but the longer you're in the field, the more you start to figure out how vital signs work. Um, and some things you're going to look at it and be like, oh, that's not good. They get to a point where they're not just numbers anymore. Monitoring devices in a patient, let me get to the right slide. There we go. In a patient experiencing an allergic reaction, pulse ox can be a useful method for assessing the patient's perfusion status, mainly in the sense that if you get a good number, if the number looks good, then they probably have good perfusion. Um, if they're starting to vasoconstrict out in their extremities and go the shock route, you're not going to get a very good number. It may be that it has a hard time reading. It gives you a stupidly low number that can't be accurate, that kind of thing. The decision to apply oxygen should be based on airway patency, work of breathing, and abnormal lung sounds on auscultation, not solely on pulse ox readings. So, like I said, sometimes those numbers can get a little out of range of where they need we'll say calibration. In a sense, is that yeah, the device may be working, but don't trust the numbers. All right, so treat your patient. If your patient looks like they need oxygen, give them oxygen. And then your reassessment is pretty much always going to be the same. If it's a bad reaction and they're unstable, how often are we going to reassess? 5 minutes. If they are stable, if it's just a contact allergy, like they got poison ivy on them, then yeah, every 15 minutes is fine. But again, usually those kind of allergies, they don't really need the ambulance. So it's perfectly fine if it's a mild allergy for them to sign a refusal and then just go to the doctor to get some calamine lotion or something of that sort. Monitor, but if it's something that you are actually warranted for, then monitor the patient's anxiety level and mental status, because those are going to be the first things to go weird when their vital signs starts to drop out of range, if they start to get hypoxic. And then watch for signs of shock. That's where we don't want it to go. Keep in mind, we can't bring people back from shock. We can only try to slow the progress of it. So the faster you get ahead of it, the better. Communicate and document. Mostly just your documentation. Make sure that you talk about the signs and symptoms you found. If you saw any injuries, bee stings, snake, bites, any of that kind of stuff. Document what you saw, where you saw it. If you gave an EpiPen, document that. Try to document, because they're so short, they're such quick burning medicine. Document when you gave it. Sometimes that's not a bad idea. Just whenever you hit somebody with an EpiPen and you're in that 10-second delay of letting it get in, just look at your watch, see what time it is. All right. Let me see something real quick. Oh yeah, we almost done. It's gonna be a real short night tonight. All right. Emergency medical care for immunologic emergencies. If your patient appears to have a severe allergic reaction, or God forbid they're going down the anaphylactic shock route by the time you arrive, administer BLS. All right. So keep in mind, the airway is going to be the main problem until they go into full blown cardiac arrest. Then now you got to worry about the cardiovascular system as well. But the airway is the issue. The blood pressure can be an issue, but that's a secondary thing, and most of your fixes for that are at the ALS level anyway. So y'all focus on the A and the B when you're dealing with this. Provide prompt transport to the hospital. If a stinger is present, scrape the skin with the edge of a sharp, stiff object like a credit card. The big thing here, and this has not changed since the dawn of time, is don't use tweezers or forceps, because these, a lot of times the stingers actually hold the toxin. So if you squeeze it trying to pull it out, you just dumped all the rest of their that venom into them. And if they're having a bad allergic reaction, what's already there, then now you've made the situation a lot worse. Once you get the stinger out, gently wash the area with soap or a mild antiseptic. Remove any jewelry. For the love of God, remove jewelry from that arm, because if they start to swell, the allergic reaction may no longer be your biggest problem. All right, they may lose a finger because their wedding ring um, is way, way, way too tight for the swelling. You saw how bad that picture was with the woman's tongue. So imagine having a ring, a hand with a ring on the finger that normally fits you snugly already, and then you swell it twice that size. You could lose a finger, you could lose the whole hand if it's something around the wrist, that kind of thing. Apply an ice or a cold pack to the area, but not directly on the skin, and not for more than 10 minutes at a time. We don't want to actually cause cold injury. So if you do use an ice pack on somebody, what I usually do is I'll ask them if they have a Ziploc bag, throw some ice water in it, and then put a towel, like a wash rag or something, put that over their skin, put the ice water bag on top of that, and say, here, hold this. We're going to keep this on you while we go to the hospital. Another option, and it's probably the more professional option if you got it, is use a cold pack that we normally use for people with hypothermia. Um, Use one of those. So they're packs that have like a fluid pack inside of them, and then there's also this crystallized powder, for lack of a better word. You grab the pack, you twist it, squeeze it so that it pops that water pack on the inside. That mixes with the crystals, gets really, really cold, and you can throw that on them. It's the same thing. All it is just one you had to pay for, and the other one you just got out of the freezer and faucet. Be alert for signs of airway swelling and other signs of anaphylaxis, such as nausea, vomiting, and abdominal cramps. Don't give the patient anything by mouth, especially if they're already started, because if they're going to swell in that area and you give them something by mouth, they're very likely to choke on it. Place the patient in the supine position as indicated and give oxygen as needed. And monitor your patient's vital signs. Monitor them frequently. Like I said, if you're concerned about it, you don't have to wait 5 minutes. The big thing about that 5 and 15 is basically to get you to understand that the worse your patient, the more often you want to check those vitals. Be prepared to provide further support as needed. All right. So for your epinephrine is a sympathomimetic hormone. In other words, this is what your body releases whenever it needs a sympathetic nervous system response. That is your fight or flight. That's your oh my God, I'm being attacked. My blood pressure is going to climb. My pulse is going to climb. My eyes are going to dilate so that I can see better in the dark. It's all of your defense mechanisms kicking in. If the body creates it, it's called adrenaline. If we built it in a lab and stuck it in a needle, it's called epinephrine. It's the same thing. This causes the blood vessels to constrict, and it reverses vasodilation and hypotension. So epi is kind of like the wonder drug for almost everything EMS, right? We give it for heart patients, we give it for cardiac arrest, we give it for these allergic reactions, just because of what it does. It's fantastic, but it causes the blood vessels to constrict, so you're basically undoing what the body's doing, because in that sense, it's also going to make your bronchioles dilate, and now they can actually breathe again. Um, as it says there, it does reverse vasodilation. We can use it to bring up blood pressure. As the advanced providers, you guys as basics won't use it for that reason, but it will do that. Um, it increases cardiac contractility and relieves bronchospasm, and it rapidly reverses the effects of anaphylaxis for about 3 minutes. So again, epi is not necessarily a one and done. In fact, a lot of your EpiPens now are coming with 2 doses. Epinephrine is prescribed by a physician and comes pre-dosed in an automatic epinephrine injector or an EpiPen. There is an adult dose and a pediatric dose. Some EMS systems are authorized to carry epinephrine as part of their regular onboard meds. Most of them do, but if you're able, use your patient's epinephrine. Like, use your patient's EpiPen. If they've got one, hit them with theirs. Um, it's already prescribed to them, and it's at a dose that's meant for them. Give me a pen and like 5 refills. Yeah, so that's good. That way, because like I said, you never know how long you might be in that reaction. Refer to your local protocols or consult med control. That's always your last ditch thing. Like, if you don't know, um, call the doc or your supervisor or whatever. All allergic emergency kits should contain a prepared auto-injectable syringe of epinephrine. That's what you see in the picture. Um, and these are pretty straightforward. You pop the black tip off. Well, the cover's already off of that one. You pop the main cover off, put it on the side of your leg, lateral mid thigh. Press in until you feel the needle release. Hold it for 10 seconds so that the epinephrine that's inside of that container has time to get into the body. Don't just immediately pull it out. And then after 10 seconds, then you can remove it, dispose of it in a sharps container, and monitor your patient. You should see a reaction from them in about 30 seconds. You should see their vitals starting to change. Hopefully, you see them starting to breathe easier. It's a fast acting, so you're not going to sit there for 10 minutes waiting to see if the epi worked. And then, but again, it's fast burning too. So have that second dose ready just in case you need it. The adult EpiPen delivers 0.3 milligrams. The infant is half that. If you're going to go into ALS, you need to definitely know that. If you're going to just for the EMT class, I don't think y'all need to know the numbers, but you can just basically see that it's not much. It doesn't take a lot of epi. All right, because epinephrine constricts blood vessels, it may cause the patient's blood pressure to rise significantly. We actually use it for that reason, especially in children. Other side effects: increased pulse rate, anxiety, cardiac arrhythmias, pallor, dizziness, chest pain, headache, nausea, and vomiting. But they usually go away just about as fast as the effect of it does. Patients without signs of respiratory compromise or hypotension and who do not meet the criteria for a diagnosis of anaphylaxis should not be given epinephrine. People in their 80s should not be given epinephrine. That's not on the slide, but just word of wisdom, because you're gonna crank somebody's heart rate up if they have a weak heart. Um, you don't want to take that chance. Some areas may allow administration of epi by IM injection. That's your EpiPen. With IM epinephrine injection, the concentration must be 1 to 1,000. You don't need to know that. So I'm actually, you know what? I'm surprised they put that in the lesson plan, but not in the slides. I guess that works out because that's out of dealing with the concentrations of epi is out of your scope. That's going to be at the AEMT and the paramedic level. So disregard that last statement. That's it for the night. Like I said, very short chapter. It's probably the shortest one in the book. Um, take the opportunity, catch up on your tests. Definitely enjoy the holiday. The next time we meet is going to be November, so enjoy your Halloween. Like I said, this is the beginning of my favorite time of the year because the leaves are changing. It's not hell outside in the temperatures. Uh, so get out and enjoy it. Tonight's pin is going to be B as in boy, C as in Charlie, 20, A as in alpha. So we have Bravo Charlie 20 Alpha. Thank you. Any questions? Like I said, this is a short chapter. It's early, so any of y'all want to go over anything or any questions about what we've covered so far? We good? All right. All right, guys. Y'all have a great weekend, and I'll see you on Tuesday.